Most people will use our emergency services, and what we found of late is that our emergency care system has become crowded and overcrowded, especially during the winter periods. There's lots of reasons for this, but the one that the hospitals struggle with the most is outflow of the hospital. So that's patients who are in our beds, who are medically fit to go home, who are waiting for social care, social packages to be set up and established, and are sitting in hospital beds that we need for the new acute admissions that are coming through, but we're unable to move those patients quickly enough. This leads to a full medical admissions unit and a full surgical admissions unit. And then the patients who need to be admitted into the hospital start stacking up both in the emergency department and outside of the emergency department in a queue of ambulances. This happens every winter, and when I say winter, winter extends from about middle of October, and we haven't finished winter yet at UHB. We are still queuing ambulances at the moment. And so, because of the job I do in the emergency department and the work I do in patient safety, we have a unique position to look at safety incidents that were happening within the ED when the system was becoming overcrowded, and also further downstream at the patients who were being placed quite often in inappropriate beds in the hospital because we don't have enough beds that we can put the patients into that are the most suitable beds. So when the MAU gets full, patients have to outlie. And we know that outlying patients have a much, much higher risk of a serious clinical incident happening to them because of provision of care. And that's because their clinical picture, that what's wrong with them, what the management they need from the nurses and the doctors, isn't matched to the skill set that can be provided on that ward. So we looked for a SHINE research grant to have a look at trying to improve patient safety in the overcrowded urgent care system. And first of all, we had to look at what the problems were. Some of these I've described already. So delayed discharges. I think almost every acute trust in our region and almost every acute trust in the country has a big issue with delays for discharge. Lack of available beds and lack of appropriate available beds. Overcrowding in the ED. We have very high medical acuity. Everybody knows the population is getting older. The patients who are coming into hospital are complex. They've got multiple medical problems, and they have a high acuity. Our resource is often full of patients, and I'm referring to a U score here, with a U score over 5 who are on NIV, are ventilated, who are septic. The ambulance queue is a huge area of risk. It's the top risk on our corporate risk register at UHB for several reasons. First of all, it has a elastic capacity. So we sometimes are queuing 1 or 2 patients. The biggest queue we've ever had is 20, and that again is a huge extra capacity that we have to look after. The patients are being nursed in that queue by a variety of people. SWAST will help us. Their paramedics will stay with the ambulance patients, but they have an SOP that when the need in the community is greater than the need in the ambulance queue, they will release those paramedics and to go out to get more patients. We then have ED nurses nursing the ambulance queue, but once we're over a certain capacity to be able to provide the ED nurses, we then have staff from the main bed base of the trust providing care for the patients in that queue. So these are ward nurses, usually from the acute areas, from MAU, STAU, sometimes ITU, but they are not ED trained. They are usually trained to look after a very narrow specialty and are not trained to look after everything and anything that can appear in the ambulance queue. These patients are also medically unassessed. So they've been assessed by the paramedics. Sometimes they've been assessed by the general practitioner, but they haven't been seen by an ED doctor. So the deterioration in the queue, these patients can be queuing for up to 4 hours before they get offloaded into the main ED. The other thing that happens during the winter is that we have a heavy reliance on agency, both for doctors and for nurses in the ED. It can't have escaped anyone's knowledge that the ED is a pretty challenging place to work at the moment, and we're having a recruitment problem like we've never had before. Doctors are leaving to go to Australia. The nurses are leaving, sometimes without a job to go to, because the winters in the ED are so very difficult for them. The teamwork is hard. Outliers is something that we've struggled with as a trust. We would like to get all the patients in the right bed, but we can't do that when we're full. And sometimes it's a case of one patient gets discharged, the next patient moves from ED into that bed, wherever that bed is. So essentially, over the winter in ED, you've got a perfect storm. You've got a variety of patients who are medically unwell. You've got no beds. You've got a reliance on staff who aren't your usual staff to provide the care. And you've got this elastic walls where you can't stop the input into ED. And what we observed when we looked at the clinical incidents that had happened in the ED were that when we are crowded, during periods of overcrowding, we are having clinical incidents related to the fact that we don't do the basics. So that's what gets forgotten. We don't do vital signs hourly. We don't do an ECG, within 10 minutes of the patient arriving. And that's what our standards would be, but because we're so stretched, those things get forgotten. We do have a high rate of clinical incidents for queuing patients. This is usually unrecognised deterioration due to multiple handovers, and also a variability in the number of vital signs being done and what they are. And there are high rates of clinical incidents, especially serious incidents, and that means sort of moderate to severe harm, for certain groups of outliers. When we looked at the incidents, patients with diabetic ketoacidosis, patients with chest drains, patients with a stroke, patients with a tracheostomy, if they outlie in a ward that isn't appropriately staffed with the nurses with that right skill set, there is a much, much higher risk of them having a clinical incident related to their care. With the SHINE project, what we aimed to do was standardise the delivery of quality across the peaks and troughs in demand of what we see. Quite simple. And it had two parts. So the first one was to design and implement a safety checklist. And essentially, it's like an idiot's guide to nursing patients in the ED. It's a time-based list of tasks that need to be completed for every single patient that is a majors type patient, so that can include majors patients who are in minors because we don't have enough beds, in our resource room and in the queue. To design the checklist, we asked the nurses and the medics to work together and say what is important in terms of the first hour of care, the second hour of care, the third hour of care. We then asked the patients what was important to them. And the third group of people that we asked in terms of designing the checklist were the paramedics and the ambulance crew. And we asked them to say, if you were queuing in the ambulance queue, what's important in terms of recognising deterioration in this group of patients? The second part was an IT innovation to try and pre-alert our site team to the fact that we had a patient in the ED that shouldn't go to an outlying ward. The examples of the patients that I gave you. And it's slightly like our Redfern, where we get a phone call from the ambulance service that pre-alerts us to the fact they're bringing in a very sick patient. And what we then go and do is prepare the resource room so that we've got a free bed to nurse that sick patient. The IT innovation was a bleepless system to let the site team know that we had a patient who was not going to outlie if we can possibly help it, so that they could organise the necessary bed moves to move a bed, to have a bed free on the stroke ward, on the endocrinology ward, and on the wards that look after chest drains regularly, which are our respiratory ward and our thoracic surgery ward. So here's an example of some of the things that we put on the checklist. So there are some things that are one-off tasks. So an ECG performed and seen by a doctor, so that we have a policy at UHB where if you do an ECG, the most senior doctor in the department at the time, either the consultant or the registrar, has to sign off that ECG, the first one that gets done. That's so we don't miss anything barn door, like a heart attack that's happening or a terminal arrhythmia. The second one are things like consider early imaging in stroke. We tried to include things that were in the best practice tariff. So CTing patients with a query stroke within an hour, X-raying patients with a query fracture of femur in an hour, and then also starting the specialty pro forma. We know that standardisation works, so that we know if patients with sepsis are managed in the sepsis 6 way, they have an improved outcome. So we wanted to document that we were managing these conditions as early as possible. The second thing that were on the checklist were recurring tasks, measuring vital signs and our U-score, pain score, scoring pain and offering pain relief, and then checking that it's worked. We're quite good in ED at assessing your initial pain score and giving you some pain relief within the first hour. We're really not very good at just making sure that's worked in the second and third hour and that you're not still lying there in pain. This is the top part of our safety checklist. It's really, really simple. It's on a poster over there. It's not rocket science, but it does provide a standardised framework for anybody who is nursing these patients to make sure that they're doing the right thing. The benefits, anyone with basic nursing skills can understand what a set of vital signs is, what a pain score is, what the use score is, and that you need to do an ECG. So it offers some resilience during the periods where we're really, really vulnerable. It provides a standardised framework, and it reduces massively the amount of freehand writing that needs to go in the notes. So we call this is the second part, we call it the nudge. It's a bit sort of Facebook terminology, but that's the way it's evolved. And this is our bleepless system where we pre-alert the site team that we need a bed, a special bed. And at the moment, the patient flow coordinators, who are the sort of admin and clerical staff who sit right at the front desk in our majors department, will be told by either the clinical team or the nursing team that we need one of these beds. They type in the trust number to the sort of pink form on the left, and which sort of bed they need, and that message then gets sent via Wi-Fi to the site team's Wi-Fi phone. It gets sent every 10 minutes, and if they don't acknowledge it, it gets repeated every 10 minits until they acknowledge that they've heard it. It then sends a message back to our computer in ED that they've acknowledged that and they're looking for a bed. And then what we haven't cracked is the final part where we say the bed is ready. That still takes quite a few phone calls for that to happen. So what we're trying to do is right patient, right bed, accepting the fact that we can't do that for everybody. What we really need is the highest risk patients to get into the right bed when we've only got a few beds. This is the ECG within 15 minutes of arrival, labelled correctly and reviewed by a doctor. So pain score and analgesia, you can see that we kind of dipped off quite a lot in December and January, but it's improving now. This is our stroke targets. They've really improved. And one of the things that we really struggled with in ED was scanning people within an hour of arrival when it gets really busy. And sepsis. So these are people who where we've documented that the treatment has commenced and we've got evidence that the pathway is there. So going forwards, this project continues till June, and then we'll do our full formal evaluation of it. We have now put the checklist in the next reprint of our notes. And then what we would like to do is to spread this work to other emergency departments who are struggling with crowding, and so that it's easily adaptable to whatever your areas of importance are. So that we can use this to standardise out what we're doing. Because SWAST are used to now doing it at UHB, that part of the project where they will be using it in the queue, if they're in your queue, will be very easy because the crews are familiar with it. And there's two things that are certain. One, winter happens every single year. Despite that, it still seems to come as a surprise in November to the trust that it's winter and we're going to have a queue and we've got no beds and everybody's grumpy. And the second is that there's no magic bullet to solve the problem that is outflow block. So we're going to be left with queuing and overcrowding for the foreseeable future. And so I think what we need to do is accept that. For a while we didn't accept that, and we kept sort of thinking the queue would stop and eventually we would solve the patients who could be not sitting in our acute beds, but we can't seem to do that. And so what we need to do is try and make the system we've got safer going forward. Thank you.